welcome back. I'm so excited for today. We don't really do a lot of guests on the podcast, but Stephen and I have been talking about how we really want to bring on some more guests. And I think this is the best guest we could start out with. We have Dr. Whittaker on today. She is a NaPRO surgeon and she has a presence on social media. I've been following you for so long now. I think ever since I started going down the NaPRO path. And I get questions all the time because I see a NaPRO doctor rather than a reproductive endocrinologist and have been for the last 3 years. And people always ask me what is NaPRO? How does it work? Why do you see a NaPRO rather than an RE? And I was so excited to dive into it all with you today. So can you kind of introduce yourself, give us a little background and why you chose to study NaPRO?
Sure. Oh my gosh, there's so much. So I'm a board certified OBGYN, so trained to do everything OBGYN, deliveries, surgeries. I went into medical school thinking I wanted to do something that encompasses the whole family, treats the mind, body, and soul, like the whole unit. And I like complicated puzzles in endocrinology. And I thought I wanted to do family medicine. And I had some personal experiences with the OBGYN field as a patient where I felt like there wasn't a lot of root cause approaches, and I felt a lack of empathy as well. And then I did my rotations right after I was a patient, and my eyes were open to different options that I could, the NaPRO approach was there at my medical school. And so I was able to see just regular OBGYN care and this NaPRO approach, and how the two, I could really see black and white, the contrast between the two. So while on the left, I was looking at, regular approach. Okay, here's the pill, patch, ring, shot, IUD, and, miscarriages happen. And I don't know. It just felt like, some of it was, I think some of the residents were a little burnt out, that I saw. So some of the approaches I think were just from an academic environment, seeing that versus seeing the NaPRO approach where they had all these answers. A woman presented and she got a whole list of answers, this really complicated surgery. And I thought that was really fascinating. And I really liked that puzzle approach to really try to find these answers. On top of that, it seemed very unique, an opportunity to provide different care that isn't really out there. And I felt like it was really compassionate and just an approach that was just really needed. And so I felt like I could really make a difference. I didn't want to just go out and just do what everyone else did. I really wanted to make a difference in women's lives. And I personally had just experienced feeling very vulnerable as an OBGYN patient. And then within a few months, I was on the other side and I felt like, wow, I think we could do better. I think this is seeking better care, and I want to be a part of that.
I love that. I feel like I wish more women who are going through infertility and just in general, women's health, they had more providers like you. I know for me, I was seeing a normal OBGYN my whole life. We don't know how long I've had endo, that's a debate in the world, right? But growing up, I had painful periods. Every doctor was always like, that's normal, that's normal, that's normal. So I kind of just told myself oh, everyone has painful periods. This is normal, right? Even though now I'm like, oh no, that wasn't normal. So at 16, I got put on birth control. Yeah, sure, it helped the pain, but it still was very painful. And then after going through a miscarriage and infertility, years later, after getting the diagnosis of unexplained infertility, I found an NaPRO doctor who was willing to see me and care about me, and was like, our first meeting, she was like, I think you have endometriosis. I was like, wait, what?
Yeah.
You're kidding, right? And she's like, no, I think you have endo. And it just went from there. So to be able to have doctors like you who just care so much. And I know I've shared on social media that I'm talking to you today, and I've had some of your patients reach out to me and be like, she is absolutely incredible. I'm so excited for you to talk to her. She's such an incredible doctor. So thank you for all that you do for the infertility community and just women's health in general, because it's so needed. It's so needed right now. So can you, I know you kind of just did this, but can you kind of just explain what NaPRO is? What is the NaPRO approach?
Yeah, so NaPRO stands for Natural Procreative Technology, or NaPRO technology, and it falls under the general category of restorative reproductive medicine versus assisted reproductive technologies or artificial reproductive technologies. And so it's really what medicine was in the 70s before IVF was here. And so really trying using medicine and modern technology to cure the disease, to find the disease and treat it. Of course, we know, I mean, not all of them have total cure, but the
Mhm.
closest thing to a cure. So we're treating the underlying cause. So it helps health, it helps with symptoms, it helps with quality of life, it helps with fertility. So it helps restore fertility so women can decide. I mean, ideally, hopefully have not only one baby, but maybe even more on with hopefully little medical assistance later. Um, it finds answers, so that helps with healing. And then on top of that, it helps with better pregnancy outcomes once a woman does get pregnant. And so it's what I think medicine should have been. And I was just thinking about this analogy the other day where rivers take the path of least resistance. So medicine saw IVF and birth control as an opportunity to kind of take the least resistant path. Now, treating root cause and finding the problem of women's health issues such as endometriosis and PCOS is a little harder. It takes more time, both on the physician's end and on the patient end. But the investment is worth it, in my opinion. And, that's for each person to look into in her case. But, as far as medical practice, I see, I take care of patients both when they're battling infertility or come to me before they have infertility, hopefully when they're young with painful periods. And also I treat them in pregnancy. And so I am able to see these outcomes and experience with patients. And as someone who not only does infertility care, but does pregnancy care, I benefit from the upfront investment as well. And it's kind of nice, you
Mhm.
kind of want to go to a doctor that benefits from their work. So I would rather put the work up front, work on the hormone dysfunction, treat the endometriosis, and hopefully the pregnancy will be better after all these years of heartache. Hopefully we can prevent miscarriage or reduce the risk of miscarriage, reduce the risk of preterm birth, bad out, and really tragic outcomes that I've seen with IVF. After
Mhm.
years of heartache of infertility, I cannot imagine on top of that losing triplets after IVF, at 20 weeks, which I've seen. So, um, yeah.
So I love that because it's all about getting to the root of what's going on. And that's something my husband and I have been on a mission from our miscarriage. Because I mean, we got pregnant the second month trying. So I was like, oh, this is going to be easy. I
Yeah.
miscarried. Let's figure it out, like why I miscarried
Mm-hmm.
so it doesn't happen again. In our heads, we were like, oh, it may be a low progesterone issue, something like that, right? That's an easy fix. I know miscarriages can be very complicated. But you know, we had no idea we'd go through now 3.5 years of infertility and where we'd be now. And the very first time I sought out care after my NaPRO doctor, or sorry, after my miscarriage was just a general OBGYN. And they kind of were like, sorry, we're not going to run any blood work or test anything unless you've had two more losses or you've been trying for a year. That was the first time I'd ever heard that. And I thought that was like insane. After like the trauma me and my body just went through with a miscarriage, I was like, how are you saying this so casually? Like, I need to have two more before you'll do simple blood work to see if it's low progesterone. And that's when actually my cousin reached out to me and she was like, you need to go find a NaPRO doctor. And I was like, what is that? And that's kind of where it all started. So,
Mm-hmm.
getting to the root, I feel is so important. I know not everyone wants to, but it like you said, just for overall health, and just feeling like a better person and just, having better, stronger pregnancies and outcomes and all that. It's so important. So, how does a NaPRO doctor differ from an RE, a reproductive endocrinologist, or like a fertility doctor?
Yeah, so they are really experts on IVF. They are IVF experts. They're really good at shutting down the cycle, putting women on birth control to kind of put them on their schedule and override that with the next cycle with injectable medications, for example. Same with IUI. They have a similar approach. They're going to override the cycle and give you strong medications to fit a certain schedule. Now, the difference with restorative reproductive medicine doctors, or NaPRO, is that we use a woman's own cycle and we work with it. And so the way I'm able to do this, it's very complicated, right? Because every given day is different for a woman for her hormones. And so it's not easy. It's much easier in a way, in a sense, to override it, at least from a medical standpoint. But if you are able to educate a woman to chart her biomarkers, then we can use that data that the woman writes down once we train her to learn in a scientific way, standardized way. We use that objective data to know where she is in her cycle, when ovulation is attempting to happen, if it's even showing any signs of attempted ovulation, and where she is in her cycle on every given day. And so based on her own data, her symptom observation, and these women, as you know, women with infertility are the most compliant, motivated group of people you will ever meet. That's a superpower in a way. So it's amazing what these women can do. They take about an hour intro class. They learn more than I learned in medical school about their body, stuff that we should have all learned in high school. It's very frustrating. That's the most common thing people say after taking this course. Like, why didn't I learn this sooner? Same with me. I didn't learn it until medical school when I started charting. Not even in medical school class. I did this separately for myself.
You're referring to Creighton, correct?
Creighton, yes, the Creighton charting. Okay. Sorry. Thank you. So the Creighton model system is what I use because it is the most standardized one that I was trained under to be able to interpret. So it's kind of like a language. Each fertility awareness-based method is kind of a language, especially for someone like me that has to interpret this data. And so it's standardized, scientific, and reproducible. So I'm able to look at any given chart when a woman walks in the door for the first visit, and I can have an idea of what's going on as soon as she walks in the door, even before she says anything. She shows me her chart, she just pulls it out, and I'm like, this looks like an endo chart. This looks like a PCOS chart. And then, of course, we dive more deeply after that and do our workup. And so we really want to know what's going on first. We don't really look at infertility isn't the main diagnosis. We're looking for a diagnosis. Infertility is a symptom of other issues. So that's the difference. If you go to an REI, they're treating infertility. If you go to me, I'm going to treat endometriosis, PCOS, hormone dysfunction, blocked tubes, or whatever it is. And of course, those can present as infertility, but that is not the diagnosis.
Right. So who's a good candidate to see a NaPRO?
Who isn't? I don't know.
I love that.
Okay, I'd say, you know what? Probably people that want a quick fix, don't want to chart, don't really want to be invested, want someone to, Now, the problem with that, there are a lot of problems. Obviously, that's why I don't do it, is basically 3 strikes, you're out. 3 cycles on, they'll do 3 cycles of Clomid. You're not pregnant, you do 3 cycles of IUI. You don't do that, you do 3 cycles of IVF. Once you strike out, what else do you have left? I mean, you don't have any money left usually, or emotional reserve. And then you have less money and you're no healthier after all that.
Wow, that's such I feel like I've always thought of it like this, like the root cause, figuring it out, but like you don't really realize everything you're fixing along the way. And that's like a huge misconception people think, because we're so used to women going through infertility in this society of like, it's not working. You haven't gotten pregnant a year. Okay, IVF is your only answer. Like that's going to get you pregnant. But that's just not the reality for so many. And even like the statistics of IVF, like the outcomes. I mean, I remember when I first looked at the statistics, I was shocked because my entire inbox was, you need to do IVF, you need to do IVF. And I was like, okay, but what? I mean, it was mind-blowing to me. So just to know that, you're having a doctor that wants to get to the root and figure out exactly what's going on, that's going to help your overall health for the rest of your life, is so important. Like, I always wonder, if we never went forward with a NaPRO doctor, and if we would have chose someone else, like, would I have ever known I had endometriosis? Because I thought like everything I was feeling was just normal. And now I'm like, oh my gosh, my NaPRO has opened my eyes to being like, this is not normal. So I love it. So, okay, if you have a patient who comes to you, whether they're new or whoever, or maybe someone that's listening right now, and they have the diagnosis of unexplained infertility, what are your thoughts on that diagnosis? And then what would be your approach to next steps?
I don't believe in that diagnosis, and I think it's a shame that that's even an option.
Amen.
Um, yeah, it's really sad. It's a wastebasket term, unfortunately.
Mhm.
We can't, and yeah, it's giving a diagnosis, though it's really the physician's lack of finding the answers, right? The burden of proof is on the physician to find that. So it's kind of giving that to the woman instead of saying, look, this is I can't find it. Please find someone else. It doesn't mean there's not a cause, but I don't know. I don't. Um, so yeah, unexplained infertility. Unfortunately, it just, to me, it doesn't make sense, and it shouldn't exist.
I agree. I agree. So what do you do with a patient that comes to you and has told you, like, I've been told I have unexplained infertility?
Basically, any patient that comes to me that hasn't been to a NaPRO or a functional doctor or someone who's looked at root cause, I start from square one. I always have them recommend that they chart. We start with cycle day 3 labs and try to figure out what the root cause is. So most common would be, hormone dysfunction, PCOS, endometriosis, fibroids, tubal obstruction, infections in the uterus, for example.
Yeah, and this takes time, right? I know
Mm-hmm.
I've had a lot of pushback, the fact that I see a NaPRO versus an RE, sharing my journey so openly, that people just think it's crazy that we're like still not moving forward with the next step. But the reality is, when you're trying to get to the root cause, it takes time. And it's a lot of like, trying to figure it out, and you're like trying to figure out everything, doing all the tests, all the blood work, and it, like, each cycle I feel like we've learned something new. And I want to talk about that with you too, because we've been doing monitored cycles or a follicular series, whichever. I think those are interchangeable, right? I've been doing that for so long now. And a lot of people are like, my doctor, my RE doesn't do that with me. Like, how do I get my RE to do that? Or like, how do I find someone who's interested in doing that? Can you kind of talk about like why NaPROs do monitored cycles? And then, kind of address some of that other, like, why don't REs do it? Or if someone wants to get this done, what should they do?
So, in general, if a doctor doesn't want to do something, it usually means they don't know how.
That's,
So,
yeah.
I mean, ask
Yeah.
them why. But so, why? Because we can. Because, I mean, people now only think of things in terms of IVF and IUI. So, I
Hmm.
can compare when you chart your cycle, each month where you know your peak day of fertility is similar to an IUI cycle, especially
Right.
even in success, because IUI is 0 to 10%, but it's way cheaper. So yeah, like in my clinic, we have a small fee that we can give immediate feedback, well, not immediate, but within that cycle feedback without a visit, to review labs after ovulation, mucus cycle score, health of the cycle overall, any other questions. And so we're very aggressive every cycle, even without a visit. So that's our IUI. But for some
Hmm.
women that have been through IUI, IVF, or only know that, it's so hard for them to comprehend that that is treatment,
Hmm.
because you aren't paying $700 or going to the clinic, but you can do a lot of that yourself and for a lot cheaper,
Hmm.
with the same or better success, and a lot cheaper, a lot healthier. Because I mean, there is a cost for IVF, not only physically, emotionally, or sorry, emotionally and financially, but also potentially there's downsides to high dose of medications. When you have unexplained infertility and endometriosis, could you spread it? Absolutely. I mean, it would make sense if estrogen causes spread of endometriosis, and I've seen estrogen because I get a lot of failed IVFs patients, and their estrogen. I look at their old labs and they're through the thousands, and I never ever would want to see that. I maybe want to see up to 400 around peak around ovulation, but I'll see that way after when it should be no more than 120 really. So there is a cost there. And then my version of IVF, the more aggressive would be a surgery, so if you need, some women, everyone's different as far as how aggressive treatment they need. And some women get pregnant just from charting, and other women need more aggressive treatment and a surgical intervention. So checking the tubes, opening the tubes, looking in the uterus, looking in the abdomen for things like endometriosis, scar tissue. So I don't know if that answered your question.
Yeah, it did. It more so like, what is a monitored cycle? Like when you're doing a follicular series, what are you looking for versus like, why you don't need answers, but like why other doctors aren't doing it? Like, what are you seeing that other doctors are missing?
Well, I can interpret the chart. So what is their mucus cycle score? What is their luteal phase length? Is it consistent? What are their hormones doing? Hormones can't confirm ovulation, but they can suggest a more healthy ovulation. And hormones, the levels are important for the health of the next cycle. They promote health of the next cycle. For some women who have severe ovulation issues, we may also add ultrasound series to watch the follicles grow. But we want it a little more than that. We're a little more picky when we're with natural cycles. We don't believe, we know based on researching this, that you don't just ovulate. It's not an all or nothing event. You need a healthy ovulation. So you want to watch a follicle reach 1.9 centimeters and collapse by 0.7 within 24 hours to be a healthy ovulation. If you go to REs, they will look to make sure the follicle hits a certain size, and then they're done. They're like, you're fine. Well, that's not necessarily true. We need to watch it rupture to confirm that the egg is released, because we're looking for a natural cycle. They don't really need that, because they're going to potentially, they can just go to sucking the egg out with IVF.
Right. Yeah, that's so interesting. So that kind of brings me to something I talk about a lot is it LUFs or is it LUFs?
I say LUFs, but
Okay, LUFs. I feel like for so long I've been saying LUFs, and then the other day,
I don't think it's wrong.
okay, the other day I heard my doctor say it like more clearly, and I was like, have I been saying it wrong like the past 2 years? So LUFs, right? Luteinizing a ruptured follicle. This has happened to me many cycles.
Mm-hmm.
I have read articles where it's more common in endometriosis patients rather than like someone who doesn't have endometriosis. Can you kind of share your point of view on LUFs, if you have treatment for LUFs, your thoughts around it, all the things?
Wow, that's a
I
hard
know,
one.
sorry, I didn't even prep you for this one at all, but
Well,
you were talking about like watching the follicles, and I was like, oh gosh, we got to talk about this.
sure. Yeah, that's probably the most challenging topic that we have in restorative medicine. And I'm working on making a protocol for that so that it can be more standardized across restorative reproductive medicine. I'm going to go talk about it with some people at a conference to try to make this
Oh, that's
more
awesome.
standardized, um, so that we can be better at it as a
Mhm.
group. Unfortunately, it's so individualized now that people are kind of having their own art in every little corner, because each case is unique. But of course, there are certain things that you need to know that you should be able to try.
Mhm.
So, I mean, it depends. I usually start with basic ovulation medications. Some people can overcome these with basic ovulation medications, sometimes Cytotec, which helps with prostaglandins, that helps release the egg. So that's some easy medication, sometimes by itself, sometimes with ovulation medications, those two together. Sometimes triggers, other times figuring out root cause, such as scar tissue and cleaning that up, um, or other nutrient deficiencies, insulin resistance. And probably for your followers, it's probably important to know what an LUF is. It's the most severe complex ovulation defect where instead of collapsing, the follicle expands. So this is what they're missing in RE if they don't follow. And this is one of the biggest interests of ours to know if someone is having these LUFs. Because what will happen is the follicle hits, let's say 1.9, and then instead of collapsing and going down to 1.2, it kind of implodes and the egg isn't released. So this is probably one of the most, I would assume this is a very common cause of unexplained infertility. And I don't know how that would translate to IVF, except I would think egg quality would be harder to get. It'd be hard to get a large number of eggs or quality eggs. And the nice thing about what we're doing is we're trying to get one quality egg every cycle. That's what you need. And your body is designed to put all its energy into one big cell. The largest cell of the human body is the egg. And men are designed quantity over quality, women quality over quantity. So you have to compromise a little bit if you're trying to harvest 20 plus eggs, 20, 30, 40 in some cases. So that's my concern with that some of these are not going to be mature eggs, increased risk of miscarriage, potentially other pregnancy complications like abnormal placentas, which we know is a problem.
Yeah. Wow. Okay. Okay. So you kind of talked about medicine when it comes to LUFs. Let's talk about like your medicine approach because I feel like I get this question a lot. Like, does your doctor not allow you? I think they get confused between a naturopath and a NaPRO doctor.
Mm-hmm.
Because they're like, oh, you can't do Clomid, you can't do Letrozole, you can't do tamoxifen. I'm like, oh, I've actually done all those, So it's not true. So can you kind of talk about maybe your medicine approach versus like maybe in more of a naturopath and or an RE? You can
It's
just
kind of
talk
a
from your
mix. It's a mix
yeah.
of both for me.
Yeah.
It's the best of both worlds.
Yeah, that's so
I have
true.
all those tools. I have the tools that I combine naturopathic, holistic, and standard medicine together.
Mm-hmm. I love that. It's so true. And that's why NaPROs are so cool. Because
That's
you have
really
really
incredible.
cool. Yeah. Okay.
Yeah, and on that note, we get a report card, with infertility. We often like to think of it as all or nothing. You want that baby, you want that positive pregnancy test, or you're a failure. Well, that's not true. Like I try to focus on your cycles a report card, your symptoms are a report card. So as you feel healthier, that's a sign of success. And let's focus on that because it's so important when you're on this marathon. It's not a sprint. We want it to be a sprint. We want a quick fix, but that's not life. And so it's nice to have these like cycle makeovers. Like look at your hormones look beautiful. Your period looks much more healthy. You don't have a lot of tail end brown bleeding anymore. You're feeling more energetic. These are all signs you're healthier. So just to
that's
put
such
that
the
out there.
beauty in this too, because like, although, we're not at the point of getting pregnant yet, like, it's like my body has improved, my quality of life has improved so much since working with a NaPRO and moving forward in that direction. So you do laparoscopic surgeries. Let's kind of talk. Let's dive into a little bit of endometriosis. We can sprinkle in a little bit of adenomyosis and lap surgeries. So, what are like the main signs for someone to look for if they're thinking they may have endo? Or what are your main signs when a patient comes to you?
Well, I made a 3-tier endometriosis self-survey on my link in bio for free, so that because it's a little complicated, there's a lot that goes into that.
Yeah.
So I love when women chart their cycle because I can talk to them about their symptoms plus look at their chart. So those are two different avenues for me to look into symptoms, both on paper because your uterus is a window to what's going on in the body. That's a gift that we have, and so seeing the health of the lining of the uterus, you can see that with the menstrual flow. And so, for example, brown bleeding at the end of the period is not normal. I'm talking about when you wipe, not like on the pad. And so, especially 2, 3 days or more means there's necrotic dead tissue in the lining of the uterus due to inflammation of that uterus. So that's one big red flag. It could be caused by other things, but of course, including looking at other symptoms in addition to that, which would include painful periods, um, especially ones that cause vomiting, ER visits, painful bowel movements, pain with urination. Like when you feel your bladder moving when you're peeing, that's a bad sign. Pain
Mm.
radiating down the legs, pain with bowel movements, um, usually lower pelvic pain, sharp cramping. Um, yeah, but I'm trying to think. I have it all listed because I really thought about it, but I did put LUFs on that too.
Oh, you
As
did?
a yes, as I have 3 tiers, so the highest level of suspicion goes on tier 1 down to lower, but still a risk factor. For
Mhm.
example, tier 3 would include I would have printed it and talked about it, but uh, tier 3 includes like nickel sensitivity, family history of endometriosis. Those are
Mhm.
significant, but tier 1 would be like ER visits and
Yeah.
significant tail and brown bleeding, for example. But pain with intercourse, especially deep pain or really severe soreness afterwards. I've had women explain that they're you know, just super sore for a while afterwards. That's not
Mhm.
normal. Um, I mean, I would argue maybe even, anything other than mild cramping is not normal to consider,
Mhm.
especially if it's cyclical. Other symptoms can include migraines and other signs of systemic inflammation, such as IBS type symptoms. So,
Mm.
um, chronic constipation or diarrhea during the menses, I think, can be, um, especially when grouped. That's why I like to group it because sometimes maybe one alone, but when you have a group, um, that will increase your
So
suspicion.
that's important for everyone listening. If you relate to one of these alone, maybe don't like automatically
Don't
assume you have
panic.
endo.
Yeah.
But if you do have a group of these, it's something to begin the conversation around because I had a group of them and I just thought they were all like I was smiling when you you were talking about the dark blood at the end of your period, like the brown blood, because I mean, I had a doctor who was a NaPRO doctor, but again, not all doctors are created the same, no matter what field they're in.
Correct.
And
Yes.
the beginning, when I first started seeing her, I mean, she was great because she'd basically do whatever we wanted, right? Like anything we asked, she was all for it, holistic approach, all the blood work, all this and that. But I didn't really feel very cared for. And I remember her handing me, like, we had done like basically 6, 7, 8 months of blood work and monitoring my cycle, the Creighton method, and watching a follicle series, all these things, and everything looked okay. But what was interesting is she didn't do the follow up after suspected ovulation to see if I actually ovulated. And
Mm-hmm.
now I understand how important that is, especially someone who has
Mm-hmm.
LUFs. I'm like, oh my
Right.
gosh, why didn't we do that? And anyway, she handed me a pamphlet and it was a endometriosis pamphlet. And she's like, do you relate to any of these things? And it was like, your period comes and you're vomiting, you're going to the ER, you're collapsing, you're passing out. It was just like such extremes that
Extreme
I was like,
only.
no, no, I don't really relate to them. She's like, well, I don't really know what else to do. So we could do an exploratory laparoscopic surgery. And I was like, do you think I have endo? And she was like, I don't know. I don't think so. So I'm like, okay, I'm not interested in going under the knife if you like my own doctor doesn't think it. Anyways, then we ended up moving from Virginia to Texas. I found my NaPRO here, and it was like that first visit. I remember she told me, I think you have endometriosis after like talking to her for an hour. And I go, why? And she named like 6 things that I said.
Mm-hmm.
And she was like, any of these stand alone, you could just think, okay, something was off. But the fact that you have like 2 or more of these, like that is a huge sign to me that you have endometriosis. And sure enough, stage 3. So it's just crazy. Can we talk a little bit about adenomyosis? I had some people asking questions of like, is there a cure for adenomyosis? Like, what are your chances of conception if you have adenomyosis? What does that look like with endometriosis as well? Does it like tack on to, your struggles with infertility? So yeah, can you share a little bit about adenomyosis? I feel like that's something that's not really talked about that much.
Yeah, that's really tricky. I do have a reel on it to try to explain it. There are 2 types. There's focal and diffuse. So focal is basically endometriosis from the abdominal cavity eating into the muscle layer of the uterus. And so you just treat that just like you do endometriosis with excision surgery. So that's pretty straightforward, I think. Now,
Yeah.
that usually isn't visualized on ultrasound. So probably what these women are referring to is diffuse adenomyosis, where it's more spread into the uterine cavity that they may have seen on ultrasound. Now, really, you can't diagnose that type of adenomyosis without a hysterectomy. So
Hmm.
there's a suspicion of adenomyosis on ultrasound that's diffuse. Does that cause infertility? We don't know. Honestly, we don't really know. Most women that have that have had children. So it's likely that it's not a huge factor alone. I don't think. That's my
Okay.
interpretation of that. Um,
So that's really important because I get that question all the time. All the time, like I've been told that I may have adenomyosis. Does this mean my road to having kids is over? The
right.
answer is no.
Yeah. No. I mean, I can't think of someone where, oh, they just had I suspect adenomyosis and I found nothing else and they couldn't get, no, that doesn't, I don't see that. I think probably they're getting ultrasounds, and then on one ultrasound, there's some suspicion of adenomyosis changes, and then they ignore the fact that she may have endometriosis. It's my guess.
Mm.
And that's the true cause of her heavy bleeding. Because why do women think they have adenomyosis? Typically, heavy periods and pelvic pain. So there's a huge overlap with endometriosis. I mean, I would be more concerned about endometriosis if someone came to me saying, I was told I have adenomyosis. Let's reevaluate and look. Let's look for endo. Because you can control endo. You can't really fix diffuse adenomyosis. Again, do you need to? I don't know. Can you manage symptoms in a fertility friendly way? Absolutely. With, I think progesterone helps. Um, Probably N-acetylcysteine, optimizing lifestyle and all the usual things. Plus tranexamic acid. Tranexamic acid is something you can take during the heavy days of the menstrual cycle as needed to manage the heavy periods. And plus, it's important to make sure your iron stores stay up as well. If you've been bleeding for many years, you probably need to get those checked as well, which is another thing that's often missed, checking ferritin and full iron studies. If you're not anemic, that doesn't matter. You still can have iron deficiency.
Oh, wow. That's so interesting. Okay. Wow. Okay. So, what are your thoughts on someone who has adenomyosis and endometriosis? Like, I've had people ask me that too, because I mean, I have both, but we believe my adeno is focal. And well, I've had two laparoscopic surgeries, and my doctor did say it is focal. So, like, what are your thoughts on someone who has endo and adeno? Like, are you like, oh, you can't have a child, or through proper care?
Through proper care, focal, you just treat it like endo.
Yeah. Okay.
Mm-hmm.
Yeah, good. Okay. I got this question a lot, so we're almost done. We're going to wrap up here. But your thoughts on for endometriosis patients and or adenomyosis patients, your thoughts on alcohol, like how it affects the body for those that have endometriosis. Like, do you think that someone with endo should limit their alcohol while trying to conceive, or like maybe even eliminate it, or like what are your thoughts there?
There is data to support that alcohol is an issue for endometriosis. So alcohol and trans fats are the only things studied specifically for endometriosis that cause an issue.
Oh, that's interesting.
And in general, Mediterranean diet is what benefits women with infertility. And most women, I would argue, a huge portion of women with endometriosis or with infertility have endometriosis. So my guess is Mediterranean diet in general is a good general guideline for endometriosis and infertility. But the data is clear on alcohol and trans fats. Alcohol increases estrogen in the body, so it increases risk of breast cancer, and estrogen can spread the endometriosis. So,
Mhm.
I mean, do what you want with that data. I don't like saying you can't do this.
Right,
I
right.
say, limit it within reason. Not every day. I would say, especially, I mean, personally, I would say be reasonable. An example of something reasonable would be socially, and make sure afterwards, you're hydrating, eating before and after, maybe taking some N-acetylcysteine that helps detox the liver. or something else similar to that.
Mhm.
And yeah, I mean, be aware of it just so you're on top of it. And it goes anything that goes for women usually goes for men too with health.
Mhm.
So for men, alcohol is just as important to try to avoid.
Yeah, that's important. Men, if you're listening, you hear that? It's not just us women that have to do the work
Yeah,
too. That was something at the beginning of our journey my husband had a hard time with. He was like, "Everything's coming back normal. Like, we don't need to change anything." Meanwhile, I'm like, "Okay, no more bleach. We can't use Lysol. Getting rid of all the candles in the house, like all this stuff." He was like, What's going on?" I was like, "I'm trying anything and everything. Like, I'm doing it all." He's like, "But everything's normal." I'm like, "No, it's not normal that I miscarried. It's not normal that we haven't been able to get pregnant like a year plus since, like that's not normal." He's like, "But our results are coming back normal." I was like, "No, no, 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 no." So that's so important to know. I have a little bit of a controversial question for you.
yeah,
What are your thoughts on like, this will be the last question before we close up here, but what are your thoughts on how endo comes about and how it spreads? Because aren't there like two different theories
yeah.
here?
There are two major theories. The one I was taught in medical school is retrograde menstruation, where endometriosis occurs due to menstruation and leaking out in the tubes, and that something is abnormal with the immune system and causing implantation. The other theory is that women are born with it, so it's from embryologic development and is activated at the time of the first menstruation with the activation of hormones.
So what do you believe in?
The second one.
The second one, oh, that they're
Oh,
born with
yeah.
it.
Oh, yeah.
Yeah.
I found advanced stage 4 endometriosis in a 15-year-old.
Oh my
So
gosh,
14 or
wow.
15. It was on her tubes and everything. Mm-hmm.
Sometimes I wonder that for myself, like tracking back, like I wonder if I would have had a lap surgery, when I first was feeling uncomfortable at like 14 years old, like what would they have found?
Yeah, when you screen most women, they say my first period, my first real period, not the spotting
Mm,
before, but when they started to truly cycle, most women with endometriosis, I think that's probably the most pretty sensitive way to screen people. When you're a teenager, how were they? I
mhm,
think that's a very good predictor of endometriosis. And Dr. Patrick Young has done research on this. He's very passionate about getting earlier intervention to help prevent
mm.
infertility, and how the highest chance of clearance is in teenagers if you're able to get them
Wow.
endometriosis surgery, get it when it's fresher,
Mhm.
before hopefully it's spread or before it's deeper, and cut it out completely. He has found in one of his studies a 0% recurrence rate in teenagers only. That's the only study I've ever found with that.
Wow.
Good
So,
statistic.
okay, so with that being said, with it not reoccurring at that young age of them getting it cut out, right? Um, what are your thoughts with older patients that get it done? Like, do you think that routine lap surgeries are important while trying to conceive if you still can't get pregnant of someone who has endometriosis? Or do you think like once it's all out of your body, it's gone?
Sorry, I don't understand the question. What do you
Yeah.
mean by
So
routine?
So, for someone who has been diagnosed with endometriosis and has had lap surgeries, right? Do you think like while they're trying to conceive and they're still not pregnant, a year, 2 years, 3 years, whatever, since their last lap, they should get another one to go and explore and see if it's grown back? Or do you think after that lap surgery, once they got it all, it's gone? Do you think
So
it
typically
grows back?
in my train, well, those are two different questions. So, okay, so when do we consider yes, it can recur, and why that is it a true recurrence, of microscopic disease, or was it missed? It's hard to know. It
Hmm.
probably depends on the case and the surgeon. I'm sure it does, right? And the appearance of endometriosis because it can change throughout the cycle. So I've done a diagnostic on someone, and then I'll bring them back for the robotic surgery, and I won't see sometimes the same implants.
Wow.
So then the one, I think it was that teenager too, where it was someone young. It was on the tube, and I didn't see it during a robot, but I had noted where it was, and I excised it, and it came back positive. It could not see it. So, that's probably
Wow.
a reason. That's one reason for recurrence, microscopic disease, change of appearances throughout the cycle, which is kind of nice when you do a diagnostic in a robot, which that's super controversial. I've been
Hmm.
attacked for that as well, but I have
That's
a
crazy.
whole reason for that. And yeah, I think the outcomes are phenomenal when I do that and I
Mm.
get a better clearance decreased complication rate. And I don't have the best surgeon in the world sitting in a corner, my favorite surgeon that I would pick to do that to help me. Let's say if I need a bowel resection for the patient or urology, they aren't there.
Mhm.
And most hospitals don't have that type of
Mhm.
availability. But anyway, so recurrence risk for non-excision can be over 60%, especially if the surgeon is not trained to be able to visualize all appearances. It's very complicated to be able to identify it. It takes time, it takes a skilled eye and training. So I think a lot of it is physicians aren't trained to be able to identify it. You need to have certain techniques, including close look laparoscopy and a systematic map of the abdomen and pelvis to make sure you don't miss any area, because it's easy to do if you don't have a systematic, scientific, reproducible way of looking at the pelvis. You will inevitably miss an area. So if you have an untrained eye, or you burn the surface, or you do it too quickly, you rush it, you're going to have a 60+% recurrence rate. Or in those cases, I think many of them were never treated appropriately. So residual disease. Now, if you have someone that's thorough, excises it all, the risk of recurrence is 0 to 25%. 0 being those young women that present early, and 25% probably being more women with endometriomas, big balls of endometriosis.
Mhm.
Those tend to rupture. Those are harder to find. There may be smaller ones that you can't see because you don't have x-ray vision through the ovary to see if there are any smaller ones forming. So those are the more likely those women to recur. So for someone with NaPRO specifically or RM, what I was trained is once you hit the 18-month mark, that's when you start thinking 18 months since the first surgery to consider looking again. Now, if someone has another very clear explanation, severe male factor or LUFs, we might not jump to that, but it's nice to talk about it. At that
Mhm.
18-month milestone, that's when I start thinking about it again. Are there adhesions that can cause issues, and or is there endometriosis that's still there that was not
Yeah.
visualized before or grew
That's
from
so
microscopic
interesting.
disease? Yeah.
Wow. Wow. Okay. All right. Last but not least, how can someone find a NaPro doctor? Like, if someone is like, okay, I want to switch to NaPro, or I'm starting out my journey, or whatever it may be, how do they even where are you? Where are you located?
I'm in Pennsylvania.
Oh, okay. Okay. I knew you
Yeah.
were East Coast, but I wasn't even sure where. Okay. So, how does someone find a NaPro
Sure.
doctor?
Well, first, I would say just start charting with the cranial model system. Find a
Mhm.
fertility care practitioner, which means someone who teaches the cranial model system. She'll help you learn your cycles, help you talk you through your red flags on your chart and any issues, and get started. And she's going to know who her closest doctor is and who she trusts and get you set up. So that's the best way. You can find a teacher of the cranial model system at fertilitycare.org, or you can find a whole bunch on Instagram. Some do like virtual consults. Some people, they have them all over the world that you can do in-person visits as well, and many different languages. And again, it's taught the same way around the whole world,
Mhm.
which is pretty neat. There are NaPRO doctors around the whole world as well. But yeah, fertilitycare.org is the first place you could to start. You can go to mycatholicdoctor.org to do a telehealth NaPRO doctor if you don't have one in your state. You can contact St. Paul VI Institute in Omaha
Mhm.
to see if traveling to them would be best, or to find one closer to you. Yeah, talk to a practitioner. Could message me as well. I'm okay but I'm not great at knowing everyone. And then I'm hoping one day my husband and I would love to make a database of providers so that women can kind of also give their feedback so that you
Yeah.
can have an idea of what you're going to get
Oh my
into.
gosh, that would be
That's a
amazing.
dream one day. We'd love to do that. Oh, and also
Oh.
there's a NaPRO user group on Facebook. That's another place to ask
Oh, that's great.
for NaPRO doctors and opinions, and if there's any close to you.
So does someone have to be Catholic to see a NaPro doctor?
No, but that is important to know, is that most, it is so different. It's such a different way of thinking. Where does this come from? I mean, the whole foundation of NaPRO was started due to a Catholic doctor who didn't want to participate in IVF. And so his faith is what led him to find this scientific, um, advancement. And so that's mostly who we are. It's not everyone. We have Mormons that are leading research. We have, I think, I'm not even sure. I know people that are not Catholic. I don't know what they are, but
Mhm.
we we I mean, it's for anyone. I think it's good care. I have a lot of Somali Muslim patients that love it. I have patients of all backgrounds uh, who are looking to this for either financial reasons because it's a cheaper alternative, because it's more natural, or because whatever faith they are, this is more in line with their faith beliefs, whatever that is,
Yeah.
you know. And so it's good to know most NaPRO doctors are Catholic, and so
Mhm.
that is part of kind of
Well,
how we got here.
right. So
But
just
it's
note they're not gonna give you birth control. You're not gonna do IUI or IVF with them. So if
Yep,
that's something that you're looking for and interested in, NaPro isn't
right,
your path.
yep.
That would be, yeah, someone else. Okay, so where can people find you?
Find me on Instagram
Yeah.
at NaPRO Fertility Surgeon. That's my
Yeah, she's
handle.
really great, y'all. Y'all need to give
Oh,
her a
thanks.
follow. She's really I'm, like, so impressed. I'm like, "Yes." Like, I love that a NaPro is out here, like, helping educate and doing the reels and all the things, like, a lot of things that, like, a lot of doctors don't like to do, so I love it. So,
That's a
thank you
lot out of my
so much.
comfort zone. So, but you know, it's just getting the info out there. You know, it's so
So
sad
important.
the stories that women message me are the ones that come to me every day and say, "Look, I was told everything's fine, and
Mhm.
I know something's wrong," and all these women and all these heartache, all these stories, and so hopefully this can help some people.
Yeah. Well, thank you so much for being here. We so appreciate you.
Oh, thanks for having me. And your presence is impacting so many women and couples,
Oh, you're so
and
sweet.
making them not feel alone. So
Well, thank you. We're doing it together.
exactly.
One reel at a time.
Yes.
All right, guys. Thanks so much for listening, and we'll see y'all next time.